So thank you everyone. Thank you everyone for coming today. I am Dr. M. Ribnick, and I will give you a little bit of background about myself in just a moment. But thank you again for coming today for the mental health clinicians as suicide loss survivors echo today. I will try to stay on time. They know I have lots of slides, and no matter what, you will get them. If you've been to some of the other presentations I've done, some of this may be review, but hopefully it will still be, of interest to you. So, like I said before, my name is Dr. M. Ribnick. I'm an LPCCS here in Ohio. My PhD is in counselor education and supervision. My dissertation was published back in December, How Counselor Supervisors Experience Client Suicide. My work background, I worked in resident services at Kent State University for 7 years, including round-the-clock work, so a lot of work during summer and even during longer holiday and winter breaks with whoever was living on campus at the time, and that could be a motley crew. I also worked in emergency psychiatric and crisis services here in Portage County, and then I worked as a mental health provider with a large regional campus for Kent State University. I'm a little over 10 years experience now as a clinical supervisor. Currently, I'm the director of the Criminal Justice Coordinating Center of Excellence at NEOMED. And then outside of that role, I also work as the training, CE, and certification coordinator for Light After Loss, a nonprofit organization in Stark County, Ohio, that specifically works with individuals who are the survivors of suicide loss. So as I like to do anytime I do a presentation on this topic, and please feel free to drop things in the chat. If you feel comfortable doing so, I'd love to, I think it's helpful to share not just who you are, but in particular, why did you choose to come to this topic? What about it is important to you? What has you interested? So before we start talking about how mental health clinicians experience, being a suicide loss survivor, just want to do some level set with a little bit of data. As you will see, this is an older study from back in 1999 that estimated up to 50% of individuals that die by suicide have seen a mental health provider at some point in their life, right? That's super vague, super vague. That could be literally anything. There have been some more recent studies in 2018. This one was published that took a slightly smaller set, looked at folks who died by suicide between 2014 and 2017, but they found about the same percentage, a little more than 50%, were currently engaged in mental health treatment at the time of their death. Of that 54%, again, close to 50% had been recently released from psychiatric facilities, which we know is a very, very high risk time for folks that were specifically hospitalized for suicide risk issues or for making an attempt. We know that that's a huge kind of a danger zone for them, is really those initial days after they are released from such a structured environment and before they become engaged with either their IOP or their typical outpatient services or case management. So as you can see, this happens, right? So the whole point of kind of putting some of this data out there is really to kind of just point out that folks who are on mental health treatment do die by suicide. It can happen really at any point in their treatment. There's not necessarily, outside of this little subset of those released from psychiatric facilities, there's not really a known, kind of time that would be universal of when someone's in treatment, and this might be a risk. As we know, suicide risk is amazingly individualized. So it really comes down to that individual client and of course, their work with their therapist or whatever mental health provider they're working with. So one of the things that I also like to do, again, as a level set before we start talking about how mental health clinicians may react to the suicide death of a client, is just to remember that any type of death could trigger some kind of reaction, right? It could be a grief reaction, it could be a trauma reaction. A lot of that has to do with what was that relationship, how did that person find out about the death, what maybe was their involvement. Sometimes case managers that are doing, home visits might have a different level of involvement. I have spoken with folks who they discovered their client and had to call, 911 and they had already passed on from suicide. Others, it's maybe a phone call from coroners, it's finding out from a supervisor, maybe it's finding out in the newspaper or social media. There's a lot of different things that can impact how someone may react. But the bigger message here is what I always press, which is having this reaction or grieving the death of the client doesn't make anybody less of a clinician or professional, and it in no way indicates a lack of competency or ability to work in our field, right? So it's also okay to acknowledge that we may have separate and differing experiences, right, on the personal grief side that can also become part of just kind of those overall reactions. And honestly, when I first started talking about this topic, I tried to separate what were personal reactions versus professional reactions. You can't. Like they're just reactions, right? They're just some of them maybe you see more at work because they're specifically work task related, but these are just the reactions that can occur. So again, keeping in mind that these reactions can be very individualized. This is just to hopefully give you some insight about what those could be and a little bit of why. So when talking about the why, like, how significant these reactions may be, and this really isn't a way to try to project or predict what either your or maybe a supervisee's or a colleague's reaction to a client suicide might be. These are just things that are going on with us that are a part of that reaction, right? How we take care of ourselves, what our own professional or personal or both stigmas are about suicide, our experiences with suicide loss prior, our experience with loss in general prior, gaps in education and supervision, right? Personal morals, personal beliefs, things that bridge that gap between, our personal background and our professional experience. But these are also very concrete things too. How long you've been working, in this field. Have you experienced this before in your professional work, right? There's a lot of things that are a piece of who we are as mental health clinicians that becomes part of how we may react. So I want to highlight a little bit about what are some of these reactions to client suicide. As you can see, there are some that are more on the physical side, sleeplessness, restlessness. Some people even, will report, physical body aches, feeling physically ill. Sometimes that's related to shock. Sometimes that's related to grieving. But there's a lot of emotional reactions. Moods can go down, irritability, anger, sadness, shock, right? Lots of despair, difficulty with just day-to-day stuff, whether that's at home or at work or interacting with clients. There can be those difficulties. And for other people, there's not, right? One thing I've talked about in a previous one is when I experienced a client suicide loss, I was told at the start of my 10-hour shift and I stayed and I worked because that's what I needed to do. And I had a whole slew of these reactions later on. But one of the ones that I always like to highlight is this idea of helplessness. Helplessness is a very common reaction to client suicide, in particular for all suicide loss survivors, but we also see it really key up with mental health providers, primarily because, what was our role with that person, right? We were perceived as the ones who were going to fix this, or we were the ones that were supposed to be helping them so that this wouldn't happen. So there can be a very strong feeling of helplessness. Part of that is also driven by the fact that suicide is a decision that somebody else makes that we are, as survivors, left to react to. And that's a very helpless feeling. You can't change it. You can't fix it. You're just kind of left in this space of reacting to it. And that's really where a lot of that feeling of helplessness can come from. Some other things, particularly that you may see a little bit more in work environment is, not feeling confident or competent in work skills. There could be a lot of that questioning about my own capabilities. Should I be in this field? I've talked before about with supervisees who are chronologically younger in the field, they don't have as much experience, are much more vulnerable to that question of should I be here? There's worries about litigation that overall are not justified, and they still happen very frequently. We see this in the individual and also in the organization. There's can be fear about interacting with similar clients, whether that's just clients in general with suicide risk or clients that I call it mirroring, right? So if I had one of the suicide losses I'm a survivor of was a 16-year-old non-white male. And what could have happened with me was that I might have a fear of that group of like working with adolescents or maybe with adolescent males. And so I had a fear of this like clinical contact with that particular group. That can definitely happen. So those are things that we can see happening in the work environment. I've talked about this study before, but I always want to reiterate here that Ohio Must actually did a study back in 2016 right here in Ohio of mental health providers, psychologists, psychiatrists, case managers, social workers, counselors, to really understand their reactions to suicide loss. And there's a couple key pieces of that I always like to bring out just for folks to reflect on and kind of think about. One is that 92% of the folks in the study believed that the suicide was preventable. I want you to hold on to that little nugget for a few minutes that, 92% believed that the suicide was preventable. Many of them had concern about family. They themselves had negative interactions with their own families. And then 13% took time away from work. No timeline of how long. Could have been a few days, could have been a couple weeks, could have been a couple hours, but they took time off. 15% considered retirement. And 33% of those mental health clinicians who experienced a client suicide loss considered leaving the field, or at minimum considered a career change within the field. So these were folks who at minimum wanted to leave clinical work. So they were maybe wanted to stay in the mental health field, but didn't want to be in a clinical role, or some of them were leaving the mental health field completely. So I always highlight this as maybe something we don't think about in relation to how mental health providers, may react to a client suicide, but this is also a workforce, related issue. This has impacts how clinicians are treated after a client suicide has impact on them staying in the field and on our larger workforce overall. But again, keep that 92% in your mind. Write that down somewhere so you remember it. So some of the other reactions: blaming themselves, feeling that sense of failure to prevent the suicide. And this could be, honestly, this could be increased by how other people interact with them. So my mother does not work in mental health. She never has. And obviously, I talk to my parents, but I don't give up confidential information. But she read about, or she knew about from someone else. She happened to be friends with the nurse who attempted to provide care, life-saving care, to the 16-year-old that died by suicide. So she heard from her friend who was the nurse about this kid, and it was a very violent death. It ended up involving 2 counties. It was a big thing. And she came to me because she had seen it on the news and be like, well, they said he'd just seen somebody. So how, well, how does that happen? Like, that must have been someone, who didn't do a good job. And I'm just sitting there not being able to disclose to her, that was me, so there can also be what others are saying kind of around the person that can have an impact on, do they blame themselves, how they blame themselves, in particular colleagues and coworkers, especially if they start getting more isolated at work, or if other colleagues and coworkers don't know how to express support or just, being present with them, that can all, really get internalized and become something very different. When someone feels responsible for a suicide, so again, keep that 92% in mind, right? 92% of those in that study here in Ohio truly believed that the suicide was preventable. It's possible they are also feeling responsible for the suicide. And sometimes it's feeling responsibility by, I didn't catch it, I didn't do something, this happened on my watch. Those are all still messaging of responsibility that we are saying to ourselves. When this happens, in particular, mental health providers have much more intense emotional responses, much more, rapid changes in mood, isolation, depressed mood, really feeling, sadness, that helplessness starts to permeate into other areas of their life. There's also this much more pronounced low self-esteem and a significant increase in that data about professional competencies, right? Which then starts to translate to, should I be in this field? And how other people, again, are reacting around them can reinforce this. I've talked before about scenarios where a mental health clinician experienced a client suicide, and the first thing that happened was their supervisor canceled their sessions for the day and sent them home. That is absolutely going to reinforce, like, oh, maybe you shouldn't be doing this. Or like, we don't trust you to do this right now. We don't want you seeing clients. Those are the things that people are taking in and internalizing. At the same time, there can be a traumatic growth from this, right? There can be ultimately positive things that can come from this type of experience. Off the bat, increased awareness of suicide risk, increased, engagement with assessing risk, with how we're managing clients that have suicide risk. Those things go up pretty much, not necessarily immediately, but with good supervision, with good support. These are things that can be, again, post-traumatic growth that come out of this type of loss. In the inpatient settings, whether it's a residential facility, a group home, hospital, even in the jails, what we see is an increased use of observation, right? So keeping eyes on that person, interacting, with folks that have, indicated suicide risk a bit more often. We see more use of that one type of intervention. And then one of the other things that we see, again, as very much a growth possibility, is better communication and information sharing among treating clinicians. Even at an agency, reading notes isn't the same as the clinicians coming together and talking, or having good treatment team meetings about clients, where you're bringing in the psychiatrist, the counselor, the case manager. If they're at a residential home, maybe the group home supervisor, other folks that are engaged with this person, and seeing them in different roles and different settings and at different times. That's how you have good holistic supportive care for someone who's experiencing suicide risk. Supervisors in particular had, some interesting reactions there. Some of the things that they've talked about, and this is straight from my dissertation, is, some systems-based issues that kind of added to their response when a client completed suicide, was them feeling that they didn't have a lot of training about this. They didn't have a lot of training about how to guide supervisees through this experience, not feeling empowered at their agency, in some ways feeling overwhelmed with the supervisees that they had. They also felt pretty much the same emotional, cognitive, personal, professional reactions as the direct care provider, shock, sadness, surprise, helplessness. So that's why, supervisors can also be loss survivors. They still have knowledge of that person. They were still touched by that individual, through, the guidance and care. So they have some additional layers, of course, as supervisors, and they had some different reactions that shows, again, that post-traumatic growth about, increasing their supervisory interventions to support their supervisees, making changes, to their supervision practices after this death it demonstrates some learning, again, that idea of growth after a significant event. And then kind of the last thing that they talk about, and I touched on it a little bit, was this idea of, how the agency responds has a direct impact on the clinician, whether they're a supervisee or they're fully licensed. If the agency is projecting any kind of like thoughts of blame, whether intentional or unintentional, through like a review process, or how they kind of navigate with that person right after, can have a huge impact. And this came up a couple times in my study, where participants had supervisees that, specifically because of how they felt treated by the agency, that was kind of the linchpin where they chose to, at minimum, leave the agency, and in some cases leave the field, because of how they felt treated after this. So again, when you're a suicide loss survivor, you're having your reaction, but in a way, you're also reacting to everybody else's reaction. And I say this from experience. As an individual, I'm a 7-time over suicide loss survivor. Some of these have been in my personal life, some of them in my professional life. One or two have been intriguing crossover situations. But I can tell you, as a loss survivor and as a mental health clinician, that was very true, right? I was trying to navigate my own reactions and also experiencing other people's reactions, maybe because they didn't know I was involved, or kind of navigating when they felt the need to express their personal opinions of suicide as part of interacting with me. Like that's something you find yourself kind of also being given to you, I guess, if you will, in conversation sometimes as a survivor, is other folks will, sometimes tell you their personal beliefs about, suicide. So now you're kind of also handed that to try to navigate with folks that you love and that you respect. And, so it can be, quite a bit. And when you're a mental health clinician, I think there's also that expectation, right? We're helpers. This isn't supposed to happen. And we're not necessarily great at having the conversation that it does happen. And it's not that it's okay that it happens, it is the reality. And how can we kind of prepare ourselves and prepare our colleagues and our supervisees, if you're a supervisor, and the other folks at your agency for, when this happens. I am very comfortable talking about my losses now. It's uncommon for me to get upset. I think the only time I get upset is once a year, when I attend or when I know that a particular event is happening. It's an event that was very important to one of the people that I lost. So when that event happens, I think about them a lot. That's a rough day. That's an anniversary for me. But I can also talk about them very objectively in the clinical sense, as well, for those that I was the provider for. So that's a difference between now and when it initially happened. But I can still tap into, and I can remember what people said to me, how I felt. It's a loss. There's grieving. It can be very traumatic. So you got that trauma kind of interwoven with loss with folks. So these are just things to be keeping in mind. And the last thing I always try to put out there, and it's part of why I share about being a loss survivor, is that I know I'm not alone. I know there's other loss survivors. I meet them every time I talk about this. A really close friend of mine is a loss survivor. So I always try to reinforce that anyone in this identity isn't alone. And hopefully today just maybe provided some insight to what folks have gone through that maybe you've known, or maybe you're seeing yourself, in some of this, if you've gone through this, and to hopefully reinforce that, again, you're not alone. Other folks have these reactions as well. So that is my presentation of just the information and just kind of the data that's behind it. But I'm also happy to take questions or talk through a scenario if there was one submitted.